Good afternoon. My name is Greg Hansch. I serve as Executive Director of NAMI Texas, which is the Texas affiliate of the National Alliance on Mental Illness. NAMI Texas is dedicated to building better lives for the millions of Texans affected by mental illness. We have 27 local NAMI affiliate organizations across the state and approximately 1,700 members made up primarily of individuals and families whose lives have been affected by mental illness. Thank you for the opportunity to testify. I encourage you to focus your discussion, but not limit your discussion to the three-legged stool for mental health care. Those three legs are community-based care, crisis care, and inpatient care. All three legs of the stool rely on each other in order for the stool to stand. For example, when funding for community-based care was cut in 2003, the crisis system and the inpatient system were strained. Many of these costs were felt by local taxpayers. We must build up all three legs to ensure that individuals with mental health conditions are able to access the right level of care for their individual needs. But we must also focus on the ancillary services that can affect an individual's ability to engage in other services. This should include services like housing, supported employment, and peer services. In many cases, these services are a precursor to effective engagement in the mental health system. To that end, we hope to see better options for step-down housing for people in state hospitals, more supportive housing options for public mental health clients and state hospital patients, and a renewed focus on peer services in the Medicaid system, in the criminal justice system, and the community. Peer services are delivered by those with lived experience who are trained to support others who have been through similar challenges. Cutting across all of these segments of the system are the challenges that our state has with building and sustaining a mental health workforce. We have over 15 million Texans living in mental health professional shortage areas. Over 80% of counties in Texas have this designation. These workforce challenges affect all aspects of the public mental health system. On the community mental health level, surveys of the centers have found that many centers struggle with the inability to offer competitive compensation to recruit and retain staff. One center found that caseloads doubled during the pandemic, leaving workers stretched thin and unable to provide the necessary level of personalized client focus. Another center is no longer able to keep one of its crisis respite facilities open 24/7 due to staffing shortages, which disrupts client services and makes the open hours busier and more challenging for providers. Other centers report having to combine multiple clinics into one facility, making access more challenging for clients who once lived near a now shuttered location. This is all at a time when demand for mental health services has surged considerably. The most important step the legislature can take to addressing the workforce needs in the community mental health system is providing funding to address workforce gaps in that system. The appropriations bill has funding to maintain pay raises for staff at state hospitals and other facilities, which is encouraging, but the community mental health workforce was not included. It's important to address this. Another key step for the legislature to take is facilitating statewide access to coordinated specialty care, which is the gold standard in care for early psychosis. We should ask ourselves, if people don't get access to proper care for early psychosis, what will be the consequences for individuals, families, schools, and communities? Some of these consequences will be dramatically negative. Fortunately, we're at a watershed moment for access to this critical service, which is generally operated on the local level through the community mental health centers. 29 centers have coordinated specialty care. 10 of them do not. These coordinated specialty care programs are largely federally funded. Texas currently only has 20% of the capacity that it needs for coordinated specialty care. The appropriations bill has funding to establish 4 additional programs. We're asking the legislature to add 6 programs on top of the 4 already funded in the Appropriations Act to help close the gap between need and capacity. In the broader spectrum of community mental health services, it's important to acknowledge that the wait lists for community mental health services have gone down. From September to December last year, the adult wait list went down from 924 to 297. This is tremendous progress. At the same time, keep in mind that just because someone is no longer on the wait list doesn't mean they're getting the precise array of services that they need. Local mental health authorities are required to comply with rules that detail multiple levels of care for clients. The higher the level of care, the more robust the services. The level of care that a client is recommended for corresponds with their level of need as indicated by a clinical assessment. Per a July 2021 report by the HHSC OIG, many LMHA clients deviate from their clinically recommended level of care. This is often because a client refuses the higher level of care, but sometimes it's due to addressable issues like resource limitations. We must take a hard look at our community mental health system to understand not just are people actually receiving services, but are they receiving the services that match to their needs? Because if people don't receive access to the appropriate community mental health care, they're more likely to end up needing crisis services or inpatient care. HHSC funds community-based crisis services, including crisis stabilization units, extended observation, crisis residential facilities, and crisis respite facilities. There are also 24/7 crisis hotline and mobile crisis outreach services statewide. Under the All Access Texas initiative, which you heard about a little while ago, many gains have been achieved in crisis services, and many regional stakeholders have identified the need for additional crisis programming. For example, in Representative Gerdes' area, rural serving LMHAs have begun using smartphones and tablets to collaborate with law enforcement remotely. Through equipping law enforcement with technology for remote evaluation, LMHAs are seeing increased access to care for people needing an assessment, as well as effective system navigation for law enforcement. The capacity to perform remote evaluation also allows for the resolution of the case on the scene in some instances. But these practices are not broadly adopted across the state. The limited programs like these that do exist are often federally or locally funded. With an expanded state role in crisis services and with expanded broadband capacity in rural Texas, many gaps of time and distance can be closed while increasing access to crisis care. The last year has seen a seismic shift in the crisis system with the national rollout of the 3-digit number for mental health crisis calls, 988. Easy access to the existing lifeline is a positive step and will result in more people accessing crisis services. However, it is straining our existing crisis infrastructure. Nationally, the 988 lifeline received over 1.7 million calls, texts, and chats in its first 5 months. That's nearly 500,000 more than the old 10-digit suicide prevention lifeline number fielded during the same period the year before. Furthermore, a segment of those who call the lifeline or the... Yes, please.
Were those numbers...
Chair recognizes Representative Gerdes.
Thank you. Those numbers you're just talking about for the suicide hotline, no, is that national or just in state?
Those figures were national. However, surges are being reported at the 5 suicide prevention lifeline call centers that we do have in Texas. Significantly increased demand. By some predictions, we will see in the year following the July 22 rollout of the 988 a 2 to 3-fold increase in demand for call centers, crisis call center services.
So when they call in and what do they send somebody out or they go pick them up?
It depends on
what does that look like?
The vast majority of calls that come into 988, the lifeline, can be dealt with over the phone. Roughly 80% of calls can be dealt with over the phone. In the instances where there is a greater level of need, they have the capacity to send out a mobile crisis outreach team, which is a team of mental health responders who can usually then de-escalate the situation without having to bring the person to a facility. There's going to be a small sliver of those calls that require a person to be brought to a crisis facility, like a crisis respite, a crisis stabilization. And we need broader capacity for all of those services because we have an overall shortfall in our state.
Right. And then on the LMHA remote evals, you said they were utilizing those in my district.
Correct.
Particular.
Yes.
I mean, about what percent do you think is the counties using that for remote evaluation to kind of prohibit some folks from going where they shouldn't be going?
I don't know that data point. I suspect it's a minority of counties. That programming is modeled after an initiative in Harris County. that the Harris County Sheriff's Office implemented several years ago, and it's being replicated. It's shown to be very effective, but it's not broadly adopted across the state. Thanks for the questions. Yes.
Chair Representative Tinderholt.
Thank you, sir. I appreciate it. So I'm going to go backwards just a little bit.
Sure.
You mentioned a wait list that went from 900 and some to 200 and some. That's a wait list for a mental health facility, is that?
Community-based mental health services. There is a wait list for inpatient mental health facility services.
So what's the difference, just in short?
For community-based services, these are people who can be served while living in the community.
Okay.
So going to a local mental health center in their home community, whereas the wait list for facility-based services, inpatient care, those are usually people who are under forensic commitments, who are criminally justice involved, or who are at risk of harm to self or others. And there's a wait list for both of those populations.
So do you know what the wait list is for the other one?
For the other one, forensic wait list is about 2,500 people. And those are people who are generally waiting in jail for access to services. It's a big issue for us.
I didn't know there was two separate numbers. I wanted to make sure we cleaned up the numbers if they weren't, because those people in jail shouldn't be in jail and they need to be on some wait list, and it sounds like they've already done that, so I appreciate you.
Absolutely. And I think that issue of the forensic wait list really speaks to the need to build out additional capacity in our inpatient care system. And I do hear that there is an idea to establish a facility in Tarrant County, and that is something we would strongly support.
I think it's going to happen. I think it's going to have to happen in all the larger counties, but thank you.
Absolutely. And on the topic of inpatient care, just fast forwarding a little bit, we think that the state's additional investment in inpatient care can be maximized by providing funding to HHSC to secure a Medicaid IMD waiver. The IMD exclusion prohibits Medicaid from paying for care for longer than 15 days for adults. States have the option of securing a waiver from CMS that allows for Medicaid payment for longer stays in mental health hospitals. We just have to apply for it, and with a minimal cost to the state, we can achieve generous federal returns and expand access to inpatient care and further our general revenue investment in inpatient care. We've also talked a lot today about the criminal justice system. Tremendous efforts are being made there in diverting people away from that system. The All Access Texas initiative is a legislatively directed initiative that focuses on increasing access to mental health services in rural Texas communities. There's a lot of collaboration there happening in rural areas, and that's facilitated by HHSC. 8 rural serving LMHAs have implemented jail diversion projects for people with mental health conditions. That's resulted in over 3,500 diversions from jail into treatment, and that saves a lot of money for local governments. So we should see an expansion of projects like those, and we're pleased to see that the Appropriations Act has a proposed funding increase for the mental health jail diversion grant program. We also encourage the legislature to support the proposed funding to allow the Texas Correctional Office on Offenders with Medical and Mental Impairments under TDCJ to pay their staff a higher wage. These professionals play a key role in reducing recidivism and reincarceration among individuals with mental health conditions. They achieve incredible results, and we need to pay their staff better because they're losing staff to other treatment providers. You can also address mental illness in the county criminal justice system by hearing several key bills referred to this committee, including HB 484 by Representative Mesa, which strengthens suicide prevention initiatives in county jails, HB 1400 by Representative Moody, which authorizes the establishment of multi-county assisted outpatient treatment programs, and
Okay, sir, we have to move on without talking about bills, please.
I had a feeling.
Thank you.
No problem. Sorry about that. Just wrapping up my testimony, those are really the main points I wanted to cover. I do appreciate the opportunity to testify. I appreciate bills that have been filed by members of this committee and your work on these issues, and we look forward to working with you this session.
Thank you very much, Greg. Other questions? Representative Jones?
So when you talked about Texas only has 20% of the capacity for the mental health crisis, or what's impeding the ability for us to reach 100%, or even not that's flunking. I mean,
Yeah.
if 60 is, I mean, that's horrible. So
Yeah. Yeah, and that's for coordinated specialty care, which has received pretty strong bipartisan support we've seen over the last few months. That is for people experiencing early psychosis. I would say the two barriers that come to mind in terms of making that a statewide initiative, one is the workforce, the challenges that I spoke to previously, that we don't have the supply of mental health professionals that we need. So we need to build out that pipeline and then retain existing professionals that we already have. And then two are the resources to fund those services. The state
resources means money.
Yes.
Okay.
And there is money in the appropriations bill to fund coordinated specialty care. It's just not enough to accelerate our progress towards closing the gap.
Going towards that, so one of the things I've noticed since I've been in the legislature since May 18th of last year is whenever people come to testify before the committees, it's always people who are trying to get money from the state, like the state agencies, TDCJ, whoever. What I don't see, but I think would be equally as important, because for us to make good public policy decisions to actually deal with actual crime, not crimes, issues, is for the end users of the product, like families of people who have people who locked up. Wouldn't you want to know from the people that are locked up whether they're being treated well, whether their relatives are being treated well? So I think it's hard for us. So I don't just presume because a state agency asked for money, they need it for what they need it for, right? Because a lot of people in my family have been locked up, some today, and before I was born. But I don't want to vote to give money to people that are treating people inhumanely.
Right.
Because if people are treated inhumanely when they get out, I mean, we're creating monsters. That's the first thing that I want to say. So I'd actually like to see that, where it's not so one-sided, because it just seems like regular people aren't important, only state agencies are important.
May I just make a brief comment
Yes.
on that? I just want to clarify who I'm here representing with NAMI, which is an organization made up of individuals with lived experience.
No, I understand that, but I'm like, you're like a big organization. There are like regular people like my family. Before I got elected, I never heard of NAMI, right? Mm-hmm. And I have individual experiences with my family that are locked up in the county jail and TDCJ. And so we need more than just big agencies. There are people with stories to tell that could really help us get insight into what's really going on, because to throw money at a problem without knowing everything that's going on, I think is just setting us up to fail. But you said something about 988.
Yes.
And you said that it was, these are my words, like crushing the capacity. It's overburdening the system
Right.
that exists. Like how so? The people are calling and they need what, and what don't we have?
Right. Well, the fact that it's now easier for people to access the Lifeline because it's a 3-digit number that's being fairly well publicized. It's gotten a lot of media coverage as opposed to the longer 10-digit number that existed previously. So there's just a broader awareness that that resource exists. The problem is when people call that number, some of them are going to need more than just someone to talk to on the other end of the phone. They're going to need real crisis services, face-to-face crisis services. And we don't have the capacity that we need currently to meet that need.
You don't have the capacity because you don't have enough people taking the calls. You don't have capacity because you don't have enough, I guess, contracts or referrals to other places.
It's both. So not enough call center capacity. There's not enough people to take the calls. And that's why a lot of calls end up going out of state that come from Texas, which is a concern. And then secondly, we don't have the services, mobile crisis outreach, crisis stabilization, crisis respite for the people with that higher level of need. Those services are not broadly available enough in our state, and we would like to see an investment made to bring those services to communities that are currently underserved, which are many communities across the state.
So to that end, with the workforce that you need, do you need people who have gone to school, like maybe social workers and stuff? So we need to provide money maybe for people to go to school and get educated at that, things like that.
When it comes to addressing the workforce challenges, that's a whole conversation in and of itself. I would say, for one, we would like to see, and this is in the appropriations bill, an expansion of the mental health student loan repayment assistance program, which will provide students coming through schools of social work and counseling, the ability to fund their education, incentivizing people to enter this profession, which is not a glamorous profession, and then to stay in the profession for the long term. So that will make a big difference in addressing the workforce shortages that we have in our state.
So here's what I'm going to do, because I got a gajillion questions and I'm not about to ask them here. I'd love for you to come to my office.
I will.
We can talk so that I can figure this out, because my mother had a social work degree and couldn't get a job, ended up being a postal worker. So
I was just there, and I will come
Okay.
back. Good.
All right.
Thank
Okay.
you. Thanks
Thank
for the
you.
questions.
Thank you. Members, any other questions? Okay, thank you for your testimony. Chair calls